Hello and welcome. In this presentation, we'll be looking at the classification, risk factors, comorbidity, and pharmacological intervention associated with hypertension in regards to a case study. This presentation could apply to different hypertension patients, in particular those who seek lifestyle modification. It could also prove useful to those who prescribe it, such as an accredited exercise physiologist. What we will cover: overview of the client, a 7th Joint National Committee classification of hypertension, the significance of systolic hypertension, comorbidity associated with hypertension, pathophysiology of cardiovascular disease and stroke, client lifestyle modification advice, and lastly, pharmacological intervention. Overview of the client. Tom is a 56-year-old male seeking professional advice for lifestyle modification. He smokes, drinks, rarely exercises, and has a diet high in saturated fat. His blood pressure is 147/88, and his BMI is 33. The Joint National Committee 7th edition classification of hypertension. Blood pressure is widely regarded as an easily measurable symptom with powerful prognostic value in exposing asymptomatic underlying disease such as coronary heart disease, cerebrovascular disease, cardiac failure, renal disease, and peripheral arterial disease. High blood pressure is not only prognostic of underlying disease, but has been implicated in subsequent decline in the function of vital organs such as the heart, brain, and kidneys. The 7th report of the Joint National Committee clearly outlines the classification of pre-hypertension, stage 1, also known as essential hypertension, and stage 2 hypertension. Patients need only fit one value to be recognized under that category. Here we have the 7th Joint National Committee classification table. As you can see, Tom fits in the middle in stage 1 essential hypertension with a systolic blood pressure greater than 140. Blood pressure can be further categorized into both systolic and diastolic hypertension. Very high risk of cardiovascular disease is associated with systolic hypertension. Systolic hypertension is characterized by a systolic blood pressure greater than 160 and a diastolic blood pressure less than 95. Traditionally, diastolic blood pressure had been solely implicated in disease arising from hypertension. Contemporary scientific belief now views systolic blood pressure as the same, if not more important than, identifying the causes and likelihood of disease arising from hypertension. Despite this, many clinical blood pressure modification practices still place an emphasis on the reduction of diastolic blood pressure. Technically, our subject Tom falls in a stage 1 essential hypertension, as mentioned previously. Essentially, the target of any intervention, whether it be lifestyle modification or pharmacological intervention, is to render the patient normotensive, or as close to this goal as possible. The 7th Joint National Committee report illustrates a 5 to 20 millimeters of mercury reduction in systolic blood pressure associated with a 10 kilo weight loss, which highlights that this is not an unreasonable target. The significance of systolic hypertension. The cause of systolic hypertension in hemodynamic study has been implicated to two causes: reduced arterial elasticity, which may be caused by both arteriosclerosis and aging in patients over 35, and an increased heart rate, cardiac output, and normal peripheral resistance in patients under 35. Importantly, research fails to implicate high systolic blood pressure in patients under 35 to a higher risk of cardiac failure. On a smaller degree, isolated systolic hypertension can also be caused by reduced function of the aorta, atrioventricular dissociation, chronic anemia, hypothyroidism, and in some cases, Paget's disease. In terms of epidemiology, high systolic blood pressure, irrespective of an increase or decrease in diastolic blood pressure, has proved a better predictor for cardiac events. Significance: systolic hypertension, both in the presence or absence of diastolic hypertension, can be used in the specific diagnosis of underlying physiological disease, as a better predictor for risk for future cardiac events, and as a sole goal for treatment programs, whether it be lifestyle or drug therapy. Comorbidity associated with hypertension. Cardiovascular disease mortality is the leading cause of death worldwide, with hypertension being the major modifiable risk factor. Hypertension is also implicated in the morbidity and mortality rates of stroke, congestive heart failure, and renal disease. Based on Tom's blood pressure and lifestyle components, Tom is at high risk for cardiovascular disease and stroke. Here we look at the pathophysiology of stroke. Essentially, cerebral infarction is caused by both arteriosclerosis and hypertension. Some research suggests the exact implication that hypertension has on stroke is not clear, yet it is known that ischemic stroke is more common than hemorrhagic stroke by up to 87%. Hemorrhagic stroke pathophysiology has been attributed to an endothelial cell dysfunction and inflammation causing lipohyalinosis on the wall of small arteries, which may occlude cerebral blood flow and create microaneurysms. Microaneurysms are susceptible to rupture, consequently voiding neuronal nourishment. Similarly, ischemic stroke is believed to be a consequence of thrombosis, which may generate centrally or via embolic occlusion, arising from atherosclerotic plaques commonly built up in the carotid artery or aortic arch. It is evident that the effects of cerebral ischemia are rapid due to the shortage of glucose transportation, and inability to create energy anaerobically, which renders significant injury in the absence of blood flow. Further analysis implicates blood-brain barrier endothelial cell disorders, age-related rigidness of arterial walls, and oxidative stress. The pathophysiology of cardiovascular disease. Atherosclerosis, which is the underlying cause of cardiovascular disease, stems from deposits of cholesterol in macrophage cells lining large muscular arteries. Adipositas cordis, irregular adipose bands separating myocardial cells, result in myocyte degeneration and cardiac dysfunction. Further, chronic buildup of plaque coupled with endothelial cell dysfunction and inflammation of vessel wall causes a gradual narrowing of arteries. The effect on arteries in conjunction with consequent increased total blood volume, increased cardiac output, and left ventricular hypertrophy may constitute undue vascular strain, likely to result in disorder. In other words, cardiovascular disease involves a chronic inflammatory response accompanying small-scale macrophage uptake of lipid accelerated by the presence of hypertension, which eventually results in episodes of cholesterol-dense plaques rupturing, causing local vascular occlusion and distant embolism. This pathophysiology encompasses the causative nature for cardiovascular disease disorders such as end-stable angina and myocardial infarction. Client lifestyle advice. The 7th report of the Joint National Committee proposes that weight reduction elicits the greatest decline in systolic blood pressure, followed by dietary approaches to stop hypertension, also known as a DASH eating plan, and physical activity. Dietary sodium reduction and moderation of alcohol consumption have also shown positive influence. Tom has a BMI of 33. A BMI of greater than 25 indicates a person is overweight, where a BMI of greater than 30 indicates a person is obese. To elicit the best possible result for Tom, it is suggested that he take advantage of significant health reduction behavior in the form of weight reduction via a DASH healthy eating plan and physical activity. A DASH healthy eating plan comprises of fruit, vegetable, and low-fat dairy products and is low in saturated and total fat. It substantially lowers systolic blood pressure, diastolic blood pressure, high-density lipoprotein level, and gives favorable changes in low-density lipoprotein levels. Exercise requirements consist of 30 minutes of moderate activities on most, if not all, days of the week. Hay et al. Examined 181 men and women with preventative exercise intervention. They reported a 77% reduction in the likelihood of developing hypertension. It would also be advantageous to inform Tom that reducing his alcohol intake would likely further reduce his blood pressure. Pharmacological intervention. Pharmacological intervention for hypertension consists of one or more drug therapy interventions. The role of each is discussed. The more common thiazide diuretics. The antihypertensive mechanism of this drug are 1. Reduced extracellular fluid, such as plasma, that causes initial reduction in blood pressure, and 2. Decreased peripheral resistance associated with vasodilation of arterial walls. Calcium channel blockers. Calcium channel blockers prevent myocardial cell damage via limiting intracellular calcium during ischemia. They induce vasodilation, which increase coronary blood flow, and have been shown to preserve ventricular function after experimental arterial occlusion. ACE inhibitors. Angiotensin II plays a role as a vasoconstrictor and has an ability to raise cytosolic calcium concentration in the heart, affecting the balance between myocardial oxygen supply and demand, often implicated in myocardial infarction. Angiotensin converting enzyme inhibitors, also known as ACE inhibitors, target the conversion of angiotensin I to angiotensin II, which reduces both pre, after, and overall loading of the heart. Reduced loading of the heart decreases oxygen demand, and blocking of vasoconstriction increases blood flow, creating a better oxygen supply and less cardiovascular stress, such as tachycardia. Angiotensin II antagonist drugs. Similarly, angiotensin II antagonist drugs is a more specific drug for targeting the conversion of angiotensin I to angiotensin II with similar effects to ACE inhibitors. Thank you for watching. I sincerely hope you can take some of this information away with you to aid in individual or prescription of lifestyle and pharmacological interventions associated with hypertension.